be, and my advice would be, that whenever you have enamel, and irregardless of what type of adhesive you use, you should at least etch the enamel, and usually for between 15 and 30 seconds. So you can see where it says adhesive strategies, and it crosses out the phosphoric acid in terms of the self-etch, the 1 bottle or the 2 bottle self-etch. That's not quite correct. Surely you should not use it on the dentin, but you do need to etch the enamel. And whenever I use a universal bond, which I'm using more and more of, I always, if I use it in a self-etch mode, in other words, we don't etch the dentin, I do etch the enamel. So that is something that is always done. And of course, if you're using the 4th or 5th generation, then you need to etch the dentin also. But that makes it much more technique sensitive. So let's get back to this guideline. I know this is rather complicated, but so I'm going to go through and explain it, and my take on this, because this is really based on my experience and of course my reading, but and also that I think that until really we have good solid evidence for it, I think you should be more cautious. And a lot of these materials and techniques we don't have good long-term studies on. So let's look at the vertical column, which I've listed most of the materials that are available to us today. So let's start with metal base. What would you use with metal base? Well, if you have adequate retention and resistance form, I think that resin modified glass ionomer works extremely well. I've used it for many years, and I've really had no problems with it. The only reason I would use an adhesive cement for a metal base is, again, if there was not proper retention and resistance form, and I wanted to enhance the bond to the tooth. Can you bond to metal? Yes, but it is not the strongest of bonds, but there is a way, and it is very similar to the way you would bond to zirconium. One thing you must remember, though, and here's another tip, let's say, or something to consider, is that all of the dual cured cements will benefit by light curing. The reason that you would use a dual cure cement is that because you're feeling that your light cure will not reach all of the areas, and that you still get some polymerization without the light. However, you will enhance the bond, or rather enhance the conversion of the monomer to the polymer if it is polymerized with your curing light. And of course that can't happen with metal base, maybe only around the margins. So that's one of the reasons that I would not normally use an adhesive cement for metal base. But it will adequately work, or maybe a chemical cure would be the best choice in this situation. For zirconia, of course, even though it can be rather opaque, it is not impervious to the polymerization light. So using an adhesive cement for zirconia is much more indicated. Normally, I would not use, if I had adequate retention and resistance form, I would not use any of the adhesive cements. Why? Because it's just easier to use a conventional cement like resin modified glass ionomer cement. I've literally cemented thousands of crowns with that, and I've had very good success with that. And I think that that's probably in the literature. But you have to have good retention and resistance form. If you don't, then there is a way to use adhesive cementation and we'll talk about that in a minute, on how to bond to zirconium. Now, so any of the adhesive cements could be used, but if you're using the newer 4Y and 5Y materials, certainly I would probably use resin cements almost exclusively. The reason being that we're not sure about the strength of these materials long term, and the other is that they're specifically made for their enhanced aesthetics. You could, depending on where in the mouth you're restoring and the thickness of these materials, you might ruin the effect by using a rather opaque cement. So I would want a better connection optically to the tooth, and so that would be another reason to use an adhesive cement. The less adequate, let's say, that the retention is, the more I would tend towards one of the stronger cements, meaning the self-etch or the resin with the deadened bonding agent. Now comes the most controversial part of this, which is lithium disilicate. It stands to reason that if you're doing, depending on the restoration itself, if you're using lithium disilicate for a veneer or an onlay, obviously you want to use a resin cement. There's no question about that. Which one should you use? Well, in my mind, you would need to use one of the two strongest ones. So either the resin with the deadened bonding agent or the self-etch resin cement. What about the self-adhesive cement? I would say no. If there's not adequate retention built into the tooth, I would not use it. I don't think that these materials are strong enough to hold that on to the tooth. And so, of course, resin modified glass ionomer should never be used in these situations. Now, what about if it is a crown and there is retention and resistance form and it seems good? It's not like you have over tapered or it's a very short crown. It has been said, and several people will advocate it, that you can use conventional cement in this situation if you have adequate thickness of your lithium disilicate. The manufacturer's recommendation would be at least 1 millimeter all the way around. That means at the occlusal, at the axial walls, and at the margin. That's a lot of preparation, and maybe not something that we need to do, especially in the posterior. So, should you use even then resin modified glass ionomer? And my feeling is no. That's why I put an X there, and there's no equivocation on my part. I don't use that. I just don't think it's adequate, even though it is a stronger material. It's a sort of middle strong compared to something like composite or feldspathic porcelain versus, let's say, zirconium. But that is my take on it. At minimum, I would use, with that kind of situation, I would use as I said, a self-adhesive resin cement. But usually I would go for a stronger cement, just to be sure. I want to sleep at night, and I know that with those cements, that it will be, lithium disilicate will be working at its top means. In other words, it's sure to work the best. Self-adhesive, I think, may be a compromise that I don't want to make. What about lucite reinforced or any of the others that are much weaker than the aforementioned materials? Those, I think, are obviously need to be reinforced. The material itself needs to be reinforced, and they need to be, therefore, they need to be cemented with the strongest cements, which are the resin with the bonding agent or with the self-etch resin cement. I would not use self-adhesive in those cases, even if there was adequate retention and resistance form. So that is my take on it. I hope you understand that, and that that has helped you in some ways. I understand that not everybody will agree with that, but that is what I do in my practice. What about the protocols? How do you go about doing this? And because there's some controversy in there too. Don't forget, when we're bonding, we are doing, there's two ways of bonding, micromechanical and chemical. In some instances, we can only do one or the other. What we would like to have is both together. Not always possible, at least not at this time. And this is the most difficult, or rather the section where I get the most questions and people are most confused about: how do you bond to non-etchable ceramics? And in this case, that means zirconia. From many authors and my own experience again, I have found that this is the best means, and I'll explain why. When you're bonding when you want to bond, you feel the need to bond zirconia. Remember, it doesn't always need to be bonded. You would try the crown in first, and then after you've adjusted and tried in and everything seems perfect, you want to gently sandblast the internal surface. There has been controversy about using aluminum oxide at all on any ceramic, even a stronger ceramic like zirconia. And the reason is that people thought that maybe you would be inducing crack formation, or with the case of zirconia, you might be inducing phase transformation from tetragonal back to monoclinic, which could have a deleterious effect on long-term success of these. I think that the literature sees that there's not a lot of worry about that. There is some controversy in those who do use sandblasting, or I should say air abrasion, better word for it, as to which type of material to use. In other words, or rather the size of the aluminum oxide particles, and how much pressure there should be and at what distance for how long. I tend to use 50 microns, and the literature mostly seems to concur that it should be somewhere between around 30 and 60 microns, and the pressure about 1 to 2 bars, or certainly not more than 2 bars. You want to use just a very, rather quickly do that. You don't want to dwell on any one area, and you need about 10 millimeters from the surface. My take on it is, rather than trying to induce any kind of roughness on the surface of the zirconia surface, I'm using the sandblasting basically to clean the surface. Once you've tried it in, and even as it comes from the lab, there's all sorts of things that are on the surface that are going to bar you from adequately bonding to that surface. So you need to clean it. And in fact, I clean all different materials, all the materials that I ever use, whether it's composite or lithium disilicate or lucite glass ceramic. I clean first the inside surface with aluminum oxide at a very low pressure. I use 50 microns, but again, there's variance in that. And then, of course, you want to rinse that out and dry it. And then, in this case, we need to remove the phosphates. You need to remove the phosphates. And I'll explain that in a minute. And there are several ways you can do that. Then you would rinse and dry it. And then we need, because we are only using a chemical means of bonding to the surface, we need to apply a primer, a coupler, something that will couple the zirconia surface to the resin, and the molecule that we use for that is a phosphoric acid methacrylate called MDP. You would apply it to the tooth, let it air evaporate for 60 seconds, and then you air dry it with clean oil-free air. Once you've done that, you can apply your cement. Just a tip here: what if you're using glass ionomer cement? Would you go through all these steps if you're using glass ionomer cement? And the truth is, yes, if you want to enhance the bond to even glass ionomer cement, you would go through exactly these steps. Why? Why would you want to use a coupler or a primer here? Well, because the resin modified glass ionomer has resin in it, and so you can enhance your bond to the restorative material by using a coupler, which in this case is MDP. So once you've done that, you place your resin cement in the restoration. Then you will seat your crown. Now, what is MDP and why do you use it? Well, MDP is a sort of bipolar material. It has two heads. It has an organic part that will grab onto the resin, and it has an inorganic end, which you can see in this case is a phosphate group, and that will chemically bond, the phosphate will chemically bond with an ionic bond to the zirconium surface. Now, we talked about cleaning. Why do you need to clean the surface? Why can't you just put that directly, on the MDP on the surface? Well, because if you've tried it in the mouth, the saliva or blood, whatever that got on there, has phosphate groups in it, usually in the form of phospholipids. And these phosphate groups are now occupying the binding sites, and your primer cannot get to it. So we have inadequate bonding. How can you get that off? Can you use chemical means, mechanical means? Well, yes, you can use mechanical means. Air abrasion would be a good choice. However, and it's a big however, are you sure you got everything off? You're not, because can you see that? No, of course you can't see that. I mean, I use at least 5 times magnification or more. Sometimes I look at it under the microscope. All I can see is that I've cleaned the surface and it seems homogeneous. So I've cleaned it from sort of macro particles. But I don't really know if I've touched all the surfaces. There's not a really good way to test for that, especially if you want to enhance the time element, because it's going to be a long bonding process. So what I do is I use some sort of chemical means as a kind of insurance policy. And there's 2 things you can use. One is, in the literature, it says that you can use sodium hypochlorite. Things like, if you're thinking about alcohol or acetone, they actually will not remove the phosphates from that surface. Sodium hypochlorite probably will, or you can use a dedicated cleaner, something that is on the market from manufacturer. Ivoclean happens to be one of them. There's something called Zircleaner. So there's lots of products on the market. You could choose one of them. And the way I know that the way that Ivoclean works is that it has zirconia particles in an alkaline base, and these great huge number of zirconium particles, because of the surface area gradient, will just pull the phosphates off to themselves. They act like a sponge, and then because it's water soluble, you can just clean this off with water in a water bath and remove them, and now you have a pristine surface. Phosphoric acid obviously is not something you want to use. You're just doing the opposite. You're putting phosphate groups back. So I use something like Ivoclean or sodium hypochlorite in a water bath, just to be sure, and that gives me peace of mind that I have really a clean surface, and now I can paint on the primer, the MDP, and it will be I will get the maximal bond that I could possibly. Here's an illustration of this. This is from Blatz in the Journal of Dental Research, and you can see on the left side where the zirconium surface has not been pre-treated either by air abrasion or the MDP. You can see that there's no bonding between the composite and the zirconium surface. There's a gap formation. Whereas on the right, it has been pre-treated with both of those, and you can see an intimate bonding between the two materials. What about cementation of etchable ceramics? This is something that's probably more familiar to everybody because this has been around longer. Just as an aside, I would like to something that I mentioned before was about enamel bonding. This is a case that I got many years ago. This was a developmental anomaly. The patient functioned perfectly well with this tooth. The problem was that the tooth had no mesial buccal cusp. Actually, it didn't have a distal buccal cusp either. This wouldn't have been a problem except that she was a model, and in photographs, she said it looked like that she was missing her first molar. What could I do about it? And so what I did was, my solution was to take an impression and make two porcelain veneers, and there they are. And these porcelain veneers have been in service now for 29 years, going on this year. This, in today's jargon, would be considered a no-prep additive occlusal feldspathic porcelain veneers. How come they did so well? Well, the main reason is, and this has been borne out by the literature, is that it is bonded to enamel. It is bonded to a hard surface. It is bonded to a surface that can be, we can make micromechanical retention with phosphoric acid, and that we can, and that the resin will infiltrate, and that this doesn't degrade as much over time as the dentin bond. Remember, this is something that you should always keep in mind when you're doing your restorations. Try to keep as much of the enamel as you can, or if you can't, if there's a lot of dentin in there, you might want to think about providing that tooth with macromechanical retention, meaning that you're doing adequate retention resistance form in your prep. Let me go back a second. This has been borne out by many people and researchers, and it shows that even weaker materials or materials that are thinner than what is normally required can do very well long term, as long as they are bonded to strong substrate, and in that case this is enamel. What about lithium disilicate? What are the protocols? It's very similar. You're going to try it in, although in this case I would not adjust the occlusion. I would wait for the occlusal adjustment until after it is bonded, just to make sure that we're not inducing some sort of crack in the restoration. Again, cleaning with air abrasion, same thing, 30, 60, I use 50, and a very low pressure. I'm not inducing any sort of roughness. Especially in this case, we're going to get the roughness from the etching, from the hydrofluoric acid etching. So that's the next step. Once we clean out the aluminum oxide, we etch the intaglio surface for, in this case, 20 seconds with 5% hydrofluoric acid. Is that the protocol for all? No. That is the protocol for just lithium disilicate. For others, it will be different. Feldspathic porcelain depends on the type of material. It could be 90 seconds, could be 150 seconds. You need to go to the manufacturer to find out what the adequate or the optimal etching time is and the concentration of your etchant. Again, this is hydrofluoric acid, don't forget. There will be, and I must point that out, that some things like lithium disilicate, there is in the literature, you can see that with more concentrated hydrofluoric acid or longer etching times or both, they do get better, seem to get better shear bond strengths. However, they do give up something in the flexural strength of that material. That is the reason that the manufacturer recommends this concentration and this etching time, because probably it is a kind of compromise between adequate retention and reinforcement of the material, and yet not weakening the material itself. And then you would clean this off. I normally put it into a water bath, an ultrasonic water bath after it's been etched. You must rinse it off. I put it into a water bath with usually warm water or alcohol, and you must dry it very well, and then you will apply your coupling agent. Again, we're going to use a coupling agent to give us and enhance. In this case, we're enhancing the micromechanical retention. Remember, if you want good bonding, the best would be both chemical and micromechanical, and in this case we use silane. And then after that, of course, you add your you either use a bonding agent, or you will directly put the resin cement on the tube. Here's the lithium disilicate as it comes from the lab. Here it is air abraded in the middle, you can see that, and then the etched surface. You can see how much, even coming from the lab, how we get a much more homogeneous surface once we use air abrasion, just to clean it from any macromechanical particles or whatever that might have contaminated the surface. And then I think we get a much better etch and therefore better bond with that. Here you can see these discs. This is Emax that I got directly from the manufacturer, and yet they're pristine. They haven't been anywhere, and yet by just using air abrasion, I can get a much cleaner surface, as you can see, the air abraded surface, and I think that we get a much better etch in that case. So what do we use on the surface? In this case, it's silane. It's a silane methacrylate. Again, it has an inorganic end. This is what will bond to the surface with a covalent bond. You can see at the bottom, and the other end of the molecule is organic, that will grab onto the resin cement. And not only is this enhancing, by the way, some people don't use silane because they say, well, we already have a micromechanical locking. Do we really need the silane? It's a plus step and more material. I think we do. Why forego that, for one thing? And the other one is that the silane is not just the silane is not just coupling the resin cement to the glass phase of the restoration of the glass ceramic. It is also wetting the surface, so you get better wetting and better flow of the material into those micromechanical interlocks. So it has a double function there, and I think that should not be. I think most of the literature shows that you get a much better bond if you use silane. Here's a flow chart. Again, not much difference between the two in terms of the number of steps. The only difference, of course, being that when you're the lithium disilicate, you're going to etch, and the zirconium oxide you can't etch. So the next step would be just chemical cleaning after the aluminum oxide conditioning. And then the linkage is also the same in terms of that you have to use a primer. The difference is that in one case it's silane, and the other one it's the phosphoric acid MDP. Okay. Some chemicals, some companies will make MDP and silane, so a liquid that has MDP and silane together. They usually also contain metal primer. Okay, we didn't talk about that, even though I said that I might mention it. Is that the protocol for metal, for bonding to metal, would be the same as zirconium. The only difference is that you need a metal primer instead of the MDP, although that works. And most of these materials have metal primer in them. However, you can get all of these, silane, MDP, metal primer, in separate bottles, and sometimes that's the best way to do them, because again, once you put everything into one bottle, it tends to lower the quality of these materials. What about the treatment of the tooth surface? We just hinted on that a while ago. Basically, in my mind, I think the best, and it's a little bit controversial too, is that is air abrasion. Again, I'm not trying to roughen the surface as much as I am to clean it. And I think that is the best way to clean it. You can use brushes, you can use chemical means, you can use ultrasound, but I think that really the best way that I have found trying all those ways is to use air abrasion. And I use that air abrasion not only for when I am adhesively bonding, I'm also using it when I am conventionally cementing. So I want to clean the surface, because as you can see, that kind of surface is what you would want for any kind of cementation. It doesn't really matter if it's adhesive or cohesive. Here's an example of a brush, using a brush in the middle. But to my mind, that is the real cleanliness you want. That is a nice, pristine surface that you could adequately bond to, or conventionally cement. I use the same protocols in terms of cleaning when I conventionally cement as when I adhesively cement. It's the same thing. I want to get the maximum amount of adhesion to the tooth surface. This has been adequately, I think, researched. I think the ones that the research that has shown that it doesn't make a big difference, those are not clinically relevant researches. They don't show any biofilm and that kind of thing, and those things make a big difference in a clinical setting. I think that everyone should have minimum a microetcher, which you see on the left, and maybe a box to collect the dust box. Can you use those microetchers in the mouth? Yes, but they create a lot of dust. So I use an enhanced kind of thing, such as the ones that you see here. That's actually my office. We have 3 of these, even though it's a small office. We use them for everything. And the reason that these more expensive units, I can control the pressure quite a bit, because you want to use very low pressure here. And it's important that you use low pressure. You don't want, because although you want to use a rubber dam whenever you can, sometimes it's not possible, especially when I'm using conventional cementation, and I still use that, but you can adequately protect the gingiva. And if it's very low pressure, even if you do, if the particles do hit the gingiva, they will not penetrate it, they will bounce off. So that is not a problem. It never has been. I've been doing this for more than 25 years. You can see here that this material, the air abrasion protocol, you will roughen basically, but you will clean any surface. And the left side, the case on the left side, you can see that it is metal and composite and dentin, and all these materials can be very well cleaned with air abrasion. Could you use the brush, or the brush and an ultrasonic unit? Yes, but you still have the problem of possibly inducing bleeding on the gingiva if you can't get a rubber dam in there. And so I think this is really something that you want to avoid. Just to go over the step by step again. This is would be a posterior, let's say, lithium disilicate crown or onlay. Of course, cleaning with air abrasion, as we just mentioned, on the intaglio surface, hydrofluoric acid in this case, depending on what material we're using. If it was lithium disilicate, it would be 20 seconds with 5%. If this were a zirconium, of course, we would not use hydrofluoric acid here because it cannot be etched, and we would not be using silane. We would be using MDP, or something, as in this case, a kind of material that has both silane and MDP in it, or one that is used separately. That needs to be air dried for about 60 seconds, and then it needs to be dried with a air syringe also. Should you put an unfilled or a dual cured bonding agent there? I put that in parentheses because not everyone uses it. I use it sometimes because I think I get better wetting of the surface and enhancement, but that is not always borne out in the literature. So that, and some people would forego that step and put the cement directly on the silanated surface like that. And of course, in the posterior, mostly you would use dual cure cement if you don't think you can actually, your light will not reach all areas of that restoration. But you could use a light cure cement. You could use, especially for an onlay or something like that, you could use heated composite. The reason for the heated composite is that of course, it's a strong material, and there's less chance of discoloration at the margin. The downside of it is, of course, is the film thickness. Is that it's difficult to do this clinically and make sure that the restoration is adequately seated, but it can be done. That is a unique technique. In terms of the tooth surface, again, I would use air abrasion to clean it. That was my go-to, and then of course the phosphoric acid, which could be selective etch for sure if there's enamel, and or total etch depending on the bonding agent that you're using. That again, do you use a dual cured or a light cured? Well, if you're not sure that you can adequately thin the material, then a dual cured may be better. In other words, this is a complicated, could be a complicated preparation. If I'm not sure that the material is not pooling in one of those angles, then I can pre-cure it with a light, and you could use a light cure. You also want to make sure that the light will adequately reach the bonding agent. So just to make sure that that doesn't happen and that we can seed our restoration, I tend to use a dual cured bonding agent in the posterior, or rather on crowns or onlays. And then of course we just seat your restoration. Please hold it in place constantly when you're cleaning up. Don't let it go because it will ride up on that cement. So somebody has to hold it, either you or your assistant, with good pressure. There are instruments you can buy for that. You don't want to have the patient bite down. You could, if it was zirconia, that's a possibility. But if it's something weaker than that, like a lithium disilicate, then we just hold it in place. And then once it's we clean it up, the cleanup. Oops, let me go back for a second. I just want to tip here. If when you clean up, you want to leave a little bit of the material on the margins. You don't want to 100% clean it up. What is the reason for that? Well, it's composite, right? You're doing adhesive resin cementation. Resin will shrink, and if it's just perfectly at the margin, it could shrink underneath the margin, and so that you would have an open margin, or even if you have a well-fitting restoration. So that's why it's important to leave just a little bead of that around the margin, and then remove that by instrumentation, so breaking it off. You also want to use a little bit on the final polymerization. You want to use glycerin on the margins to make sure that you get rid of the oxygen inhibited layer. Another tip also is that when you're using a dual cured material, it would be best to allow the dual cured part or the self-curing part to cure first. In other words, before you do this, which you should, remember that all dual cured materials are enhanced in terms of polymerization conversion by the light source. However, it's a good idea that you don't immediately hit it with the light. You let the self-cure part cure first. That could take up to a couple of minutes depending on the material, and then you would enhance it with the light cure. I normally use about a total of about 1 minute on each side before the patient leaves, not all at once, but in parts. So that would be what is the tip of the day for that. And the adhesive cementation of veneers is actually basically the same. The only difference here would be that I normally would put an unfilled bond. Again, not entirely necessary, but an unfilled bond I think wets. And in this case, it's easy because it's light cured, and your light can penetrate the veneers. It's a small, a thin restoration, and so I put it just for wetting. Make sure you drive off all the solvents and thin it out very well. And don't light cure. I normally do not light cure that. Then you would put your light cure cement. This is the biggest difference. For sure, you want light cure cement. It could be a dedicated cement, light cured cement, or it could be a flowable, or it could be a heated composite. That's really up to you. Again, the same on the tooth surface, and then a dentin bonding agent. Here you can light cure the dentin bonding agent on the tooth surface because it's a rather flatter prep. It doesn't have so many angles in it, and you can see it. It's up. You can see whether it's pooling at an angle or not. You can drive it off and thin it quite well, or you can just, if there's a lot of enamel, you might opt not to pre-polymerize this. Then you put this together. And because it's light cure, you have a lot of time. You can take your time. It's not stressed. Please hold it in place, again, with an instrument or your hand, while you're cleaning and while you're polymerizing. Okay, this needs to be immediately polymerized. And again, about a minute. Here are some tips and tricks. I think that we've gone quite, maybe a little bit over our allotted time, so I will not go through all these. Most of these things I have mentioned before, and made you aware of these. And I want to thank you. I want to thank you for your indulgence, for listening to me, and I hope that this has helped you in some way in your adhesive and conventional cementation protocols. Thank you very much.